So we have our next speaker, Dr. Rishikesh Mayeee, who is a director of Avadut Netralaya from Nagpur. And his areas of interest is, of course, visual rehabilitation in children with special needs and strabismus myopia. And he's received several awards. So without wasting much time, I would request Dr. Rishikesh to proceed with his deliver his talk.
Thank you, ma'am. Thank you, Dr. Usha, ma'am, Dr. Sudha, ma'am, and IACP for making me a part of this important instruction course on cerebrovisual impairment. Uh, I mean, most of the part has been covered except for the neurological basis and MRI findings. So, cerebrovisual impairment or CVI is also called corticovisual impairment, uh, but it involves also the subcortical parts as well. So it's an most common, or it is an important or frequent cause of visual impairment in children in the visual world, in the developed world, but also in India. Delayed visual maturation and CVI, I think that part was covered by Dr. Aditya sir. So let us move on. So the older term for CVI was cerebral blindness, but actually because of the neuroplasticity, the patient usually doesn't have blindness, and some amount of visual vision the patient usually gains. Uh, there have been revamped perinatal services in India, because of which CVI is an important cause of bilateral visual impairment in children, even in India. So the causes of visual impairment, most common is hypoxic ischemic encephalopathy. There can also be a structural abnormality in the brain or cerebrovascular accident. The most common neurological association is delayed development and seizures. So coming to the neurological basis, we start with eye, which acts as a sensory organ, where the light impulse is, I mean the light is converted into an electrical impulse and then passed into the anterior visual pathway, which also which includes the optic nerve, the chiasma, and also the retrochiasmal part till the lateral geniculate body. Usually in CVI, this part is normal, so that's why you get a normal ophthalmic examination. Then comes the posterior visual pathway, also called the geniculocarcarine tract, which or the optic radiation, from where the axons pass from the geniculate body all the way to the visual area and the visual association area. If there is involvement only at the optic radiation, the patient might have a visual field changes, and I mean even in children doing a confrontation visual field can be possible in order to get to know whether the patient has a hemianopic or a quadrantanopic defect. From there, the stimulus passes to the visual cortex and the association areas, and then it also has an integration with the other stimuli or other parts of the brain, especially the hearing and touch. Uh, and then there is integration into the motor cortex, based upon which we have the characteristic visual behavior. So any problem anywhere here, there will be change in the characteristic visual behavior of the patient with CVI. The causes include infantile. The most common is a perinatal hypoxia, and in the acquired type, it can be because of respiratory arrest, a head injury in the early perinatal period. So the visual characteristics, this part has already been covered. More important, that the patient might have visual field defects and he might have preference for light. As has been mentioned, when you are checking, don't use minimal sound or no sound, more of light. Now coming to the MRI findings of children with CVI, the most important is the periventricular leukomalacia. Uh, Leuco is white matter, malacia is loss. So basically the lateral ventricle, the part of the lateral ventricle in the trigone, there that is the part from where the optic radiations pass, and usually this part gets affected. There can MRI, according to literature, MRI does have a visual, I mean can predict, it has a prognostic value to predict the good visual outcome. So if there are no or minimal MRI findings, it suggests that probably the visual outcome in these cases might be good. So I'll share a couple of cases with the clinical findings. This is one of the patient who presented to me. This is the sagittal section T1 weighted image. You can see this, the corpus callosum is the part which I wanted you to have a look. This is the anterior part and this is the posterior part and the splenium. Here the corpus callosum is normal. Usually the splenium is the part from where there is the integrating fibers from the two cortices, especially the occipital and temporal part, they pass through this. So if this splenium is normal, the same patient, the T2 weighted image didn't show, or a few patches of hypoxic damage were seen in the occipital cortex. Uh, the clinical finding of the same patient, depending upon his mood, we have to do a visual testing, but it's basically seen that he doesn't have any a gross nystagmoid movement. He is able to follow the object. He is not trying to look up or search for the source of light. So probably the visual outcome in this case is good. So another patient, now look at the sagittal section of the T1 weighted image. You can see that the splenium is, there is a loss or volume loss in the splenium here. And the same patient, this is a flare sequence which shows that there is a reduction in the size of the optic radiations, this part, which is close to the occipital cortex. I have been following this child for 4 to 5 years now, and there has not been any significant improvement in her visual behavior. She has nystagmoid movement, and instead of following the object, she tries to constantly look up, that is towards the source of light. So the MRI findings and the visual outcome, they definitely indicate something. So coming to a few more cases, there can be, whenever there is a loss of the white matter in the periventricular part, there can also be ventriculomegaly. That space will be filled with the ventricle and the CSF, or the ventriculomegaly can also be seen in T2 weighted image. Important part is the peritrigone. The trigone is the posterior part of the lateral ventricles, from where the optic radiations they usually pass. So you can see that there is damage to the optic radiations, which definitely indicates either visual uh, uh, field defect or the reduction in the visual acuity of these patients. So MRI findings have been found not to have any gestational age. So even in a premature child can have a normal MRI finding, whereas a full-term normal delivery child can have significant MRI loss. So loss of the peritrigonal white matter indicates loss of the optic radiation. Usually complete loss of vision is not there because of the neuroplasticity. The pattern of MRI the most important is periventricular leukomalacia, which indicates a poor visual outcome. But sometimes there are minor changes in MRI which indicates a good visual outcome. So when to do MRI? When there is an obvious sign of cerebrovisual impairment, or in patients with prematurity or seizure disorders, or if the ABGAR score is low. As soon as the patient gets fitness, he should undergo an MRI. So take home message, CVI is an important cause of bilateral visual loss in early childhood, and the complete blindness is usually not there because of the neuroplasticity. The most common cause is hypoxic encephalopathy, and most common MRI finding is periventricular leukomalacia. MRI findings do have a prognostic value. They can predict the visual outcome in the individual case in the long run. These are a few references which I use for the presentation. Thank you.
Thank you, Dr. Rishikesh. It was a wonderful talk. So, in your opinion, all patients with CVI must have an MRI?
Yes, ma'am.
Must
Actually,
is it a must? It may not be of any prognostic value, but at least it would be of some diagnostic value.
yeah, it does have a prognostic value. I have been managing these cases along with a neuro physician, Dr. Parimal. So he has, I keep discussing cases with him, and he says that MRI and VP should be done as early as possible, because the previous thought process was to delay them at least for 1 year or 18 months. But the earlier you do, perhaps you can predict, or it does have a prognostic value. So whenever
I
the
think
patient gets
that's,
fitness, he should
yeah,
undergo
that's the right way to go. Thank you very much. Any questions from the audience? I would like all the speakers, to come on the stage, please, for a picture.
So, at the conclusion of this program, we just wanted to have one take home message for the people in the audience. The ophthalmologists are the first point of contact for any child with visual impairment. So when the complaints of the child and the complaint that the parents have are not matching with our findings, then we have to keep CVI in mind. Any child with even minimal disability, please anticipate vision problems. Having a visual skill questionnaire handy is very simple and easy way to manage these children. We have to talk to them about early intervention, therapy, and overall development. And please do not say that nothing can be done. Once that nothing can be done is imprinted in their brain, it's very difficult to get that idea out of their head that something can be done for these children. Thank you all.